class series. First, we are going to discuss about the ocular trauma. In that, first about review anatomy of eyeball. The eyeball, which you have an eyeball like this, and it is having a sclera. In the front part is a cornea, and it is covered by a conjunctiva. And you have the lens over here, and it is lens is just divides the eyeball into posterior chamber and the anterior chamber. And you have the iris over here, which is part of choroid. Cornea, conjunctiva, sclera, and iris are there in the anterior segment. And the anterior chamber consists of aqueous humor, which is contains sodium chloride and other ions. The posterior chamber is filled with the vitreous humor, which is a clear jelly-like substance. And when your eyeball, you see like this, and there are extraocular muscles which is attached to the sclera, and finally to the ring, and it is all covered by a sheath called as Thinner's capsule. It is a very tense sheath, and any bleeding into this compartment will cause a compartment syndrome in the eye. Also, the eye blowout of the eye is prevented by the canthal tendons, which is present in the medial and lateral aspect of the eyeball. Again, if you see the bony cavity, the orbital cavity where the eye is situated, it is a pear-shaped bony cavity, and that is also a closed compartment with a limited space, and any bleeding into this bony space will also lead to compartment syndrome. Now about the assessment of eye in trauma. So basically we have to do the physical examination. We have to check for all the three vital signs of eye. Vital signs of eye are: one is vision, second one is pupils, and third one is intraocular pressure. So about vision, near vision we have to check. Near vision we can check by using a near vision card test. If already a refractive error is there, then we have to use a pinhole test. How to prepare a pinhole is in a cardboard. We should put a small hole using a pinpoint ballpoint pen or a 0.2 mm hole, and use it as a pinhole. Or we can use a professionally available pinhole also. In pupils, we have to see for the reactivity. Poor reactive pupils is a sign of brain injury or a brain herniation. Then we have to check for swinging flashlight test. Will give us an idea about RAPD, which will give us idea about optic nerve injury. So intraocular pressure, we should use a tono pen. Handheld tonometry devices we can use. Do not press the eyeball too much and it will change the value. Press gently with the fingers and compare it to the examiner's eye or the normal eye of the patient to know if there is no tono pen. So open globe injury, we should be careful about examination. We should not check the IOP for that. Again, examination of eye in trauma will continue as anterior examination as well as posterior examination. In anterior examination, we should look for the periorbita and extraocular muscles. And third, we have to see the lids, we have to see the lashes and lacrimal glands, lacrimal sacs. Then fourth, we have to examine the cornea and conjunctiva. Then comes the iris examination. Then comes the anterior chamber examination. And finally, the lens examination. And we have to proceed to the posterior examination also. In anterior examination, first about the periorbita, we have to see for the ecchymosis, any laceration, and any concealed foreign bodies or any penetrating foreign bodies. In penetrating foreign bodies, we have to immediately refer to the ophthalmologist. It is a ophthalmologic emergency. Along with that, we can check for the protrusion of the eye. The protrusion of the eye is the outward movement, can be examined from the head end of the patient. So then we can press and see for the resistance of retropulsion. If there is resistance to retropulsion, then there is a sign of, that is a sign of retrobulbar hemorrhage. So in that case, the eyelid will be taut, it will be difficult to retract the eyelid. Then third, extraocular movements we have to check. Extraocular movements is restricted, then we have to suspect any nerve injury, orbital wall fracture, a raised intraocular pressure, etc. Next, about the lid. Lid laceration can occur, can be full thickness laceration or partial thickness laceration. Full thickness laceration is an ophthalmologic emergency. We have to do an surgery within 72 hours of injury. And if nasolacrimal involvement is there, then we have to do the surgery before the edema sets in. Partial thickness we can even conservatively manage. Then conjunctiva and cornea, corneal laceration can happen, which can be a sign of occult open fractures of the eye. Subconjunctival hemorrhage can happen. Open globe injury and fluorescent test and wood lamp examination we can do. About the iris, commonly injured in blunt ocular trauma. So peaked appearance of the iris is a sign of full thickness laceration. It can be a sign of open globe injury. So now about this anterior chamber. In open globe injuries, anterior chamber can be shallow and blood can be there in the anterior chamber, which can be dispersed, which will appear as a hazy eye, or can be layered, which will cause an increase in intraocular pressure by occluding the aqueous humor. And in the lens can rupture and can form white lens also. And proceeding with the posterior examination, we have to examine for the retina, we have to see for the red reflex of the retina. If the red reflex is absent, then we have to think of traumatic retinal detachment. Specific injuries of the eye. First, about the fracture of the orbit, which can lead to a bleeding into the compartments and retrobulbar hemorrhages. Retrobulbar hemorrhages will look like this in CT, and orbital compartment syndrome it will cause. The treatment is canthotomy and cantholysis. Cantholysis will act as a fasciotomy. Signs are reduced vision. Vision loss can occur in 1.5 hours, and asymmetrical proptosis can happen. Raised IOP and rock hard eye with the resistance to retropulsion can happen. Another problem is fracture of the inferior orbital wall can cause entrapment of the muscles, to be repaired within 48 hours. Another ocular emergency is chemical burns. So treatment for chemical burns is copious irrigation with either normal saline or RL. We can use a Morgan's lens, which if it is not available for irrigation, then you can use a blunt cut cannula for irrigating both the eyes from the root of the nose. Target is to normalize the pH to 7.0. Every 30 minutes we have to stop the irrigation and we have to check after 10 minutes the pH. If the final pH is reaching at 7.0, we can stop the irrigation. Other treatment is according to the examination, we may need antibiotic or painkillers. Now the most feared complication, the open globe injury. Signs of open globe injury are peaked pupils, shallow anterior chamber, full thickness corneal lacerations, abnormal pigmentation. One test we can do is a Seidel test, which is a fluorescent test. The color change is from dark orange to lighter orange or a green color after the test. If there is a leak, it will produce a green color. Treatment offered are immediately consult ophthalmology because this is an ophthalmologic emergency, and Rigid eye shield we can do with the paper cup, fluoroquinolones, antibiotic, catifloxacin or levofloxacin IV, minimize the eye movements, and reduce IOP by reducing the pain, nausea, coughing, minimize the eye manipulation. Do not do further examination than an visual examination. And CT scan, fine cuts can be taken for diagnosis.